So yeah, I'm going to talk about quality of life assessment in thyroid eye disease. And I'm a consultant, as Rebecca says, in London. And I've got a particular interest in quality of life assessment. My conflict of interest is that my father is a kind of international expert on quality of life assessments, and he's written quite a few books on it. So that's how I initially got interested in it. And I'm going to talk about two kind of catchphrases that we use a lot in medicine these days, PROMs and QOL, and I will explain what these terms mean in due course. And first of all, I was going to say this might seem strange to patients, but traditionally doctors haven't asked patients about what's important to them. So typically in the past we've assessed the severity of disease by looking at looking at cures or looking at biological responses to treatments, without really focusing on what is important to patients. So for example, we might do decompression surgery for thyroid patients, which is when you remove some of the bone around the eye sockets so that the eye can move backwards if it's been a bit bulgy. And a surgeon might say that the operation has been successful if the eyes move back, say like 5 millimeters or 7 millimeters. But this doesn't really look at things that might be important to the patients, like side effects, or for example, if you get new double vision after the surgery, you might not think the operation has been such a success. Or for example, with intravenous steroids, which we use a lot in thyroid eye disease, to reduce the inflammation. We measure the effect of steroid, the response to the inflammation, by things like looking at the redness of the eyes or the puffiness of the eyelids or pain behind. And we more or less have a tick list, so we can say that your clinical activity, the inflammation has reduced, for example, from 5 to 2 with steroid treatment. So we might say, oh, this treatment's been a big success. But then if as a patient you've had terrible insomnia or some other serious side effects, you might not think it has been a success. So unless we actually ask about these things, then we're not going to find out what's important to patients. And it's really been in the last 20 years or so that medicine has really appreciated that we have to find out what's the subjective patient-reported outcome, which is, we need to assess this and then and see what's important from the patient's perspective, to see whether the benefits of treatment outweigh the side effects or the complications. And also, there's also been another move in the last 20 years or so away from paternalistic medicine. So in the past, the doctor would say, well, this is your problem and this is the treatment option, this is what we think is best for you to do. Whereas these days, it's much more of a collaboration between the doctor and the patient to try and decide what is the best treatment for the individual patient. So when new treatments are evaluated, or when new clinical studies are set up these days, it's essential that you measure quality of life and you get some subjective reports from the patient about what's important in order to get ethical approval. So it's really important these days. So what is so I'll go back to the previous slide. What is a PROM? So a PROM is a patient-reported outcome measure. And this is really the report of the health of a patient's health condition that comes directly from the patient. So it's not the doctor's interpretation or a relative's interpretation, but it's a report from the patient about their health. Quality of life is a much more ill-defined term. So there's no kind of accepted universal definition of what quality of life is. So if I ask you, what is quality of life? Most people have an idea that it's to do with happiness or satisfaction with life. And it really can include lots of different factors. So it includes your general health, your physical functioning, symptoms you're having and toxicities from drugs, your emotional functioning, your cognitive functioning, your social well-being, your kind of role in society, sexual functioning, and existential issues. So there's a huge range of things which feed into what your quality of life is. So in order to get around this issue of a kind of lack of definition, most investigators will define what they mean by quality of life and work from that. So why do we measure the quality of life? So it's useful for a variety of different measures. Firstly, it's useful to compare study treatments, particularly when there's significant side effects. It's useful, again, as I said before, to get the patient's perspective of what's important. It can also help with communication to establish, again, what the patients, from their perspective, what is important. And also in establishing preferences. So, for example, in cancer trials, which a lot of quality of life studies, they came originally, the cancer work was where it kind of first came up, because a lot of the treatments for cancer can have really nasty side effects, such as chemotherapy. You can get terrible nausea or fatigue and other side effects. And yet patients will often are quite willing to accept quite severe side effects just for, to get an extra weeks or months of life. And these are things which the doctor might have thought they wouldn't have wanted to tolerate all these side effects, but patients are willing to put up with these things sometimes. And so it's important to find out from the patient what's important to them, and to decide how to make a decision. And then again, with medical decision making, we know that quality of life can actually be a predictor of how successful a treatment is. And we don't know whether this is because patients somehow have some intuition that they can kind of feel how they're doing, and this can, if they're doing well from the treatment, although that might not be apparent to the doctor, they might have a better quality of life because they feel they are improving kind of inside. Or it could just be that patients who have a kind of high quality of life perceive their quality of life to be good. This might actually influence the course of the disease. So we don't really know, but it can, basically the quality of life is associated with the response to treatments. So why develop a thyroid eye disease specific questionnaire? There are plenty of general health related questionnaires, and indeed there are quite a lot of eye specific questionnaires. But the reason why a thyroid eye disease specific questionnaire is important because we know that thyroid eye disease causes some effects on patients which are not common to other eye diseases, such as it can really affect your appearance, your self-image, and this is not something which is universal with most eye conditions, which primarily affect vision. And of course, thyroid eye disease can affect your functioning and your vision as well. So we will need something which kind of encompasses all of these things. And also, thyroid eye disease patients often will have a thyroid problem as well, and that can also feed into it. So that can feed into your quality of life. So, and also the response to treatment as well. So we know that a lot of our patients who start off as hyperthyroid, they get treatment to bring their thyroid function under control. But when the thyroid function is actually improving, they can, as a result of that, they can actually put on weight, and the energy levels can go down. So although they are medically doing well and responding to treatments, they might feel their quality of life is actually getting worse. So it's important that doctors ask about this and find out how the patient is feeling in themselves, and not just looking at the blood test results. So when I was in, to go back to the previous slide. So there are a few questionnaires which assess quality of life in thyroid eye disease. So one of the earliest ones, which was very, very vigorously developed, was called the GO-QOL. GO stands for Graves' ophthalmopathy quality of life. And it was designed in the 1990s by a team in Holland. And they asked 16 questions. So 8 are on functioning, visual functioning, and 8 are on psychosocial effects of the disease. But the questions they asked, like the first one is about bicycling, and because it was designed for a Dutch population, in the UK, many of our patients don't cycle, so it's not really relevant. And a few of the questions they ask kind of slightly strange kind of wording, like they say, do you feel that people react unpleasantly because of your thyroid eye disease, or do you feel that your thyroid, because of your thyroid eye disease, you appear less often in photos? So it's kind of slightly clunky wording, and it's also because it's quite long to fill in. Patients don't necessarily want to fill in a long questionnaire, and doctors don't necessarily want to analyze such a long one. So when I was in Canada in 2008 in Vancouver, working with a very eminent thyroid eye disease specialist called Peter Dolman, we developed this questionnaire ourselves, and we wanted to look at what were the kind of the 3 most important things in assessing quality of life for patients with thyroid eye disease. And the 3 questions we asked were: how is your eye disease currently interfering with your overall quality of life? How is your eye disease currently affecting your ability to carry out daily activities? And how is your eye disease currently affecting your satisfaction with your appearance? And it's a scale from 0 to 10, where 0 is the best and 10 is the worst. And I won't go into too much detail about validating a questionnaire, but it's a very lengthy process to show that a questionnaire measures what it's actually supposed to measure. So we look at validity is looking at whether something measures what it's supposed to measure. Reliability is looking at whether it's due to kind of random variation in responses. So if your condition hasn't changed, say for instance from one week to the next, your thyroid eye disease hasn't changed, we want a questionnaire that when you respond, give the same kind of answer, similar answer, say the first week and the second week, if your condition hasn't changed. So if one week you say have a very high score and the next week it's a very low score, it wouldn't be a very reliable questionnaire. Responsiveness is looking at the changes within an individual. So we want a questionnaire that's going to respond. So if your condition improves, then we want a questionnaire which reflects that. And if it's, and vice versa, if your condition is getting worse, we want the questionnaire to reflect that. And sensitivity looks at differences between groups of people. So if you have, say, a group of thyroid patients who are doing well, we want the results of the questionnaire to be different from those who are doing badly. So hopefully that's kind of enough information about that. So we looked at 30 patients first of all, and we asked them for feedback about the questionnaire. We also looked at various experts in the field and asked for their input. And then once we'd refined the questionnaire, we tested it on 100 patients, and we compared it to 2 other thyroid eye disease specific quality of life questionnaires, and also looked at the clinical activity scores as well. And just to summarize, and this is a very busy slide, we found that the TED poll had a very good reliability and validity, and also responsiveness and sensitivity. And one thing which was really interesting was that there was only moderate correlation between all 3 quality of life questionnaires and the objective clinical assessments. So in other words, there was a significant proportion of patients who had mild disease, but their quality of life was really badly affected, and vice versa. Some patients who the doctors thought had quite severe disease, and yet the patients thought their quality of life was actually quite good, which actually shows it's important to measure both, because if the ones who had bad disease had a bad quality of life, then there would be no point in measuring both. But the fact that there's a discrepancy there means that, we should be asking and finding out what's important to the patients. And this questionnaire is also faster to complete and easier to complete for patients. So therefore, a higher proportion of patients completed this questionnaire compared to the others. So this is now something which we routinely measure, and many patients, many doctors doing thyroid eye disease clinics will be routinely assessing quality of life, or they should be, because it's really important, as I say, to find out what the patient's perspective is. And that's all I have to say, really. Any questions?